University of Miami, who is associate professor and the director of the hearing implant program, and she'll be talking with us about cochlear implant candidacy considerations. So welcome, Dr. Holcomb, and thanks so much for joining us.
Thank you, Dr. Raymond, and thanks to MUSC for inviting me to give this talk. I do miss my Charleston folks. I'll be in town next week, well, I guess the last week of October. So if anybody wants to get together, please let me know. So this is one of my favorite things to talk about, cochlear implant candidacy. As much as we think we know everything about it, I believe especially residents and fellows have a lot to learn with candidacy, as well as audiologists who have been doing this for a while. I have a lot of disclosures. So in the beginning, really, when cochlear implants first started, it was basic and simple. People had to be pretty deaf in both ears. The audiogram looked like this. And we were not even using, difficult speech testing to figure out if folks were candidates. We were simply looking at whether or not they could interpret a noise from a voice, whether they knew spondees were different. They may not be able to even say what they were, but if they could tell that they were the same or different, you could score them that way. And then this is what the processor looked like when we started with cochlear implants. So things have changed quite a bit in terms of candidacy, scoring, and then also the technology that we're using. So fortunately, in the past 6 or 7 years, candidacy has really opened up quite a bit for adults specifically. So when you look at hey, Chris Strange, when you look at candidacy for adults, now you have acoustic and electric candidates, and then you have a standard electrode. And when you put both of these together, the cool thing is we have a pretty large area of the audiogram that is shown here for a cochlear implant candidacy. And ideally, any of you who are going to be neurotologists or making cochlear implant referrals, if you don't remember anything else about this talk, I would just take a picture of this audiogram and start sending these people for a cochlear implant evaluation. In the past 2 years, we've seen a remarkable change with candidacy that's includes single-sided deafness and asymmetrical hearing loss. Down here in Miami, I don't know what has happened, but it's like the floodgates have opened, and most of the patients, I feel like most of the patients we're seeing have single-sided deafness. They make up about 20% of our implant evals at this time. Along those lines, we're seeing more patients who have bimodal hearing, so they're using an acoustic device, a hearing aid in one side, and electrical hearing or a cochlear implant in the other side. Recent data out of Vanderbilt suggests that about 80% of candidates for cochlear implant or folks who use a cochlear implant actually have an audiogram on the opposite ear that would warrant use of a hearing aid. So we see a lot of patients who could make use of bimodal technology, and really regardless of whether it's 2 implants or an implant and a hearing aid, having something on both ears from research is definitely showing us that that's going to be a more positive effect for the patient. Likewise, in the past several years, we've seen the introduction of acoustic and electric devices. Interestingly, even though most of our surgeons here, and I know all of the surgeons there at MUSC do a beautiful job of preserving hearing, we don't really see an uptake of acoustic components by cochlear implant users. Part of that, I think, is probably because they're so tired of having something inside their ear canal that they resist moving back to that technology a little bit. Another part of it is, I think, with one of the companies, you have to use an ear mold, which really occludes the low frequency hearing. So it kind of does the opposite effect of what you would want. You don't really make as good a use of the acoustic signal. But the other thing is with the new processors that look like buttons that don't have anything on the ear, those are much more cosmetically appealing to patients. And so regardless of whether or not their outcome can be better with the acoustic component, they're still opting to not use it, which is something that we're kind of scratching our heads at down here. I think that was even discussed at ANS Super Saturday as well. So referring for a cochlear implant is super confusing. There was a lot of old data that said that you refer to for a cochlear implant if they had a pure tone average of 70 dB or worse. Dr. McCracken did a study pretty early in his career looking at unaided word recognition scores and if that correlated with aided speech testing, and really the basis of that research article was it didn't correlate. And he suggested that we should be sending more people with better hearing for a cochlear implant evaluation. Well, following a couple years later, Dr. Zwolin out of Michigan looked at this a little bit more discreetly with her cochlear implant evaluations that they had done at Michigan. And what they were able to identify is something called a 60-60 rule. This has been like life-changing for us down here. We're a neurotology practice, so we have 6 neurotologists that work in our CI center. And I think it's difficult with all of the different indications with osseous and Baha and hearing aids and implants. It's difficult to kind of wrap your head around when do you refer these patients for a CI eval. The 60-60 has been something that's been very easy for physicians to remember. So if you see a patient, just an unaided regular audiogram in your clinic, and they have a 60 dB hearing loss PTA, that's 500, 1,000, and 2,000. If it's 60 dB or worse, and then also if they have 60% unaided word recognition or worse, that person should be referred for a cochlear implant eval. Now, when Michigan looked at this, they found that using that referral criteria, they were able to correctly identify cochlear implant patients or cochlear implant candidates 96% of the time using this referral criteria. We're actually right now doing a study down here looking at our own population, which is quite different from Michigan. If you can imagine, South Florida does not, our population doesn't look quite the same as the Michigan folks that they're servicing. So we are applying the 60-60 rule, and we're hopefully going to report on that pretty soon, especially with our Spanish-speaking population as well. So it's a lot to think about, right? It's not just the audiogram anymore. It's not just the speech recognition scores. We have a lot of things to consider when we're looking at a patient. Admittedly, I'll say 15 years ago when I started in this field, we didn't really look at the whole patient. We looked at the audiogram and we looked at the speech recognition scores, and that's about as good as we were doing. Now, I think fortunately with more research on cochlear implants and more understanding of patients and their needs, we're doing a better job of servicing them. So the evaluation in the past was pretty simple. We schedule patients for a medical exam, imaging, and an audiology exam. Not too complicated. Now, it's much more complicated. We're fortunate here on our team to have 2 psychologists, and we also work a lot with the Aging Center with neuropsych. So we do have some overlap with them. And of course, we have Dr. Liu, who's a pretty well-known geneticist here. So there are a lot of options for adults to get more information about their medical history, their medical involvement, if there's a gene that's causing their hearing loss. We use a lot of questionnaires and tools to really evaluate past just the hearing loss itself and to try and figure out how the patient's everyday life is impacted by their hearing loss. It's not always the same, and 2 audiograms that look exactly the same may have a very different effect of the hearing loss, one versus the other. So one of the things we use regularly is a cognitive screener. I will say we do not disqualify folks based off of the cognitive screener. We use this more as a tool to educate their spouses, their family members. This is for the older population, elderly population. It gives us also a good indication of whether or not they, may require more oral rehab. It also gives us a better indication of some of the counseling that we may need to do with the families of how to communicate better with them. You guys down in Charleston have this famous Hollywood star, Teddy McCracken. You can see him there while he was doing his first debut on national TV for the doctors. I feel really blessed to have worked with such an amazing actor, but regardless of all that, his research is quite good. Hang on. He's spent his whole career thus far making a cochlear implant quality of life questionnaire and validating it. And it's really something the field needed. We didn't have it. We were using hearing aid questionnaires, which didn't really apply to what the needs of cochlear implant patients typically have. So in our clinic, we do use the 10-question questionnaire a little bit more often, but he does have a 35-question profile as well. It asks a lot of different questions about various parts of a patient's life, and then you can do that preoperatively and postoperatively. admittedly, sometimes we just get in a hurry and we'll say, oh, how is your hearing loss affecting your quality of life? And patients could subjectively report, oh, my quality of life is not that great. But really being able to break down exactly what parts of their life are negatively impacted the most can make for a really interesting conversation with loved ones and with the patient themselves. We use a COSI as well down here. So some of you physicians may not be as aware of this. It's a client-oriented scale of improvement. Oftentimes, I think in your clinic, you may ask a patient, well, what situations do you want to improve with an implant? And let's say the patient says, well, I want to hear better in noise. Oh, you know what? That's going to work. The implant's going to work for you. And then you send them to us as the audiologist. Well, the patient's just heard from the surgeon, who is much more important in their mind than the audiologist, that this is going to fix their hearing and noise situation. What we'll do is break that down further. So I'll say, well, what exactly do you mean by hearing and noise? Give me an example. Oh, well, when my wife and I go to Olive Garden on Sundays with our neighbors, I have a hard time understanding. And so I want to hear in that specific situation. Okay, where do you sit in the Olive Garden? Do you sit in a quiet area of the restaurant? Oh, no. We like to sit at the bar where there's a lot of people. Okay, so what that tells me is this patient's in an extreme amount of noise. And even a cochlear implant at its best is not going to fix that problem. So then you have a realistic conversation with what the concern is and how the implant will not necessarily fix it. And then you start talking about accessories and other things. So that's a very big different conversation and a different outcome than what the patient just heard from the surgeon, which was you're going to hear better in noise. So I think being as specific as possible is how we can manage some of those patients who are not necessarily satisfied after they've had their implant for several months or several years. Dr. McCracken and Dr. Moberly, who's in Ohio State, both have reported on how, post-op performance, at least what we can show by numerical values that we receive from testing in the sound booth, they don't correlate with quality of life and satisfaction reported by the patient. I think if we do a better job on the front end, maybe we can help with those realistic expectations. Another part that we do is aided testing. So we do verify hearing aids. Not all audiologists, surprisingly, verify hearing aids, but that's an important component of when you're deciding if someone is a cochlear implant candidate. We also do aided testing in the sound field. Not all clinics do that either. I don't know that it's necessary for everyone, but for me, I do like it as a counseling tool, again, just to show them where they're hearing on a graph with their hearing aids versus where I know they can hear with a cochlear implant. Having that piece of information has definitely been a deciding factor for many patients about whether or not they want to go forward with an implant. And then you get to the speech recognition testing. This is where it gets a little complicated too, because we can test in quiet, we can test in noise, and when we test in noise, we can test in different levels of noise. There are some centers who will test at a pretty extreme noise level, which is a +5 signal to noise ratio. So that means that the speech is only, excuse me, 5 decibels louder than the noise. I would caution any of you who are going into practice about doing this routinely. The research on elderly patients, especially, they do not show very much improvement in that scenario post-operatively. So you want to make sure that you are qualifying patients in a condition that post-operatively you can show an improvement. So it's just something to think about. Here we use +10, and then in specific scenarios, we might use a +5, but it's a case-by-case basis. So AZ biosentences, they're a little bit longer. You can see there on the right, some of them are 10 words, some are 7 words. She had a way of justifying any of her wrongdoing. You must live in a gingerbread house. They're kind of odd sentences, so they're not quite as simple and easy for patients to think about a normal conversation. They really do have to listen and then remember what they said and then repeat it. Sorry, I've done like 2 presentations today on telehealth. Sorry. So then we score based off of the number of words in the sentence that they get correct, and then there's a percentage score at the bottom that we calculate. So you do that in quiet and in noise. And then the third test is CNC words. So it's a consonant nucleus consonant. So an example, number one, goose, they would say ready, goose, and then the patient would have to repeat that back. If, for example, they said ready, goose, and the patient said goo, then they don't get the whole word correct, but they may get some of the phonemes correct. This is a nice test as well. It does not require as much auditory memory and cognition as the sentences. The CNC words, in my opinion, is what we should be using to qualify patients for a cochlear implant. If you're only going to use one speech test, this is the one to use. This is an interesting test to look at as well. The average post-op performance for this test is around 62%. And so preoperatively, if you have patients who are scoring considerably lower than that, then it's a good indication that there's some room for you to have improvement post-operatively. If you see that patients preoperatively are maybe scoring 60% or more, it doesn't mean that you shouldn't implant them, but it means that you should be a little bit more conservative with how you counsel them. And there's a really good paper that came out earlier this year at Vanderbilt. I think Elizabeth Perkins was the first author, specifically looking at CNC word scores. The last part of the minimum speech test battery, which is part of the CI evaluation process for adults, is a BKB-SIN. So it's adaptive noise levels. We don't use this preoperatively for our traditional candidates. We only use this routinely for our single-sided deafness and asymmetrical hearing loss candidates. And we do run this test instead of at a 0-0 azimuth, we run it at a 90-70. So we're looking at head shadow effect as well. We have a really great spatial lab here that we're getting ready to start run some cool experiments with our SSD and asymmetrical hearing loss patients. But right now, the best we're doing is BKB-SIN. So what it tells you is how loud do you need the speech to be above the noise level for a patient to score 50%. So if you remember my patient who was talking about Olive Garden, this might be a test that you would use for them to say, okay, well, let's talk about how loud the speech would need to be above your noise level for you to score 50% at the Olive Garden. And this would be a great tool to use for patients to say, okay, now you need to use your accessory, or you know what, even with accessories, it's not a situation that you're going to score well in or do well in post-operatively. So even with all that, you know, outcomes are going to vary. So pre-implant, there's a lot of factors: the duration of hearing loss, the history of your hearing aid use, whether or not you have learned language before you lost your hearing, why the hearing loss has occurred, your level of cognition, if you have dementia or some other, you know, cognitive status impairment, what your anatomy is, and realistic expectations. And then post-implantation, there's lots of factors that can cause CI outcomes to vary as well. Some of them we can control and some of them we can't control. I'd like to think that programming parameters we do a pretty good job of here, and I know you guys do there at MUSC. But things like family support, even electrode placement, and consistent CI device use, some of those things we can't specifically control. Fortunately, there's more research now with even CI device use, and so it makes it a little bit easier for us to counsel on how patients should be using their device. But this is actually a study out of MUSC earlier in 2020. So even with all those factors that are associated with success, like younger age, shorter duration of hearing loss, more residual hearing, which you think would be a huge factor, and then use of a hearing aid until the time of cochlear implantation, all of those factors together generally explain less than 40% of outcome variability. They're still significant, but we still have a lot to learn, and there's a lot of reasons that maybe we can't explain or don't yet know how to explain for why a patient does better or worse, even when they look the same as their peer. I think most of us know there's huge benefits of cochlear implants, which is why we all love them and are in this field. There's research to support that, you know, cochlear implants can increase employment and income. They're certainly cost effective. Maybe unilateral is more cost effective than bilateral. I'd like to think that bilateral is pretty cost effective too, but I'm not sure the numbers support that. There's definitely a beneficial effect of the cochlear implant on autonomy and on participation at work, greater satisfaction overall. We see a decrease in discrimination. I see this all the time with my patients. One recently who is a teacher, and she felt that she was being discriminated against at school because she was asking for assistance and different devices to help her hear the kids. She's only been implanted now for 6 months, but it's been life-changing for her. And she says, interestingly, she doesn't feel discriminated against at work anymore. And I think, because we spend probably 80 to 90% of our day at work, you really want to see improvements in your employment situation. And if this is one way you can do that, I certainly think it's a positive reason to go forward. Recent study, Dr. Zwolin again and Dr. Buckman in JAMA 2020, they looked at Medicare patients who received a CI, and I think sometimes there's a little bit of hesitance about these Medicare patients and the elderly patients in general about whether or not they're going to benefit, but they saw a median improvement of 53% for speech recognition in the implanted ear over the hearing aid only condition. Interestingly, not all states or not all clinics will implant both ears for a Medicare patient. Medicare will pay for both ears, absolutely. Well, you don't even get an authorization for Medicare. They just expect that you're going to do the right thing and follow their guidelines. But 2 ears absolutely are going to be a better outcome for a Medicare patient rather than just 1 implant. Of course, some of them will choose to keep a hearing aid on, but especially you all who are in training, ask these questions when you go to a new clinic. If they're not implanting both ears, they won't do it on the same day, but even separate surgeries, ask why. And if there is a financial reason for it, ask to see the numbers. I think we need to keep pushing the envelope forward to make sure our patients are receiving appropriate care. Another study out of MUSC, Jim Dornhofer, who I miss working with immensely, he and his colleagues looked at over 400 cochlear implant cases, and they reported on outcomes. And 85% of all of the cases that were done at MUSC in that period of time showed improved word recognition. That's a huge number, 85%. 88% improved sentence scores in quiet and 79% improved sentence scores in noise. This alone, I think, is a great research article to use to support why cochlear implants are good for patients. And even just these numbers, breaking down these numbers as simply as I did on this slide, can be a great counseling tool for your patients to move forward as well. And for your referring providers who may be hesitant to send you patients for surgery. Also, we see improvements in health. I think we all are aware that hearing loss is connected to other health conditions. A big one, huge hot topic recently has been with Alzheimer's and dementia. And, the biggest thing is that dementia risk may be up to 5 times higher with hearing loss. There's multiple reasons with this, and I think there's a lot of research being done currently to look at more specifics of that relationship. But if we can do anything to improve or to mitigate dementia for some of our older adults, I don't know why we wouldn't try that. Obviously, some of these older adults don't even have access to hearing aids, right? So just getting hearing healthcare improved across the kind of global status of hearing healthcare would be something that we should strive for. Improvements is quality of life. So we talked about Dr. McCracken's questionnaire earlier, but one of the biggest things I've seen with quality of life improvements is the range of CI technology that we have. I just had an 18-year-old in here at 3 o'clock today getting an upgrade from a Nucleus 6 to a Nucleus 7. The biggest difference, really the only difference in those devices, is that his processor would now pair straight to his phone, and so he could stream music and phone calls. I thought he was going to cry, and I think the only reason he didn't was because he was sitting in here with me, who, why is he going to cry in front of some audiologist? But his mother was in tears. She said she has not had a clear telephone conversation with him ever. He usually uses FaceTime. She was out in the hallway speaking to him on the phone, and they had a beautiful conversation, and he said it sounded like she was sitting right next to him. That seems like a small improvement to us. That's an enormous improvement to a kid who's getting ready to go to college next year and is going to be very reliant on those phone calls. Okay, so I like cases. So a couple cases, I have just 2 for adults, and then we'll move to pediatrics. So for adults, I've got a 58-year-old male, long-term hearing loss. He's had bilateral hearing aids for 20 years. owns his own company, super smart guy, very educated, very good at compensating for his hearing loss. His audiologist said he heard too well for a cochlear implant, would not send him for a cochlear implant eval. And he had been struggling for a while in his workplace and at meetings. He was on boards in his area of occupation. And he said that it was becoming more difficult to be engaged. He was embarrassed sometimes because he was missing what was being said, and he would answer questions incorrectly. I actually met him at a social event and could tell instantly that this man needed something more than his hearing aids. He came to us for a cochlear implant evaluation 2 times, and he actually scored too well. But he's a guy who filled in the blanks. So instead of telling me exactly what he heard on a sentence test, which is why I hate the sentence test, he was able to fill in the blanks and get some of the filler words correct. So then we had to give him those points correct. By the time he gets to us for the 3rd eval, he's severely struggling at work. He felt like his hearing had dropped a little bit. So we did an evaluation. So this is his hearing loss. This actually looks very similar to what my dad's hearing loss looked like before he passed away. I can't help but think now that he would have done so great with a cochlear implant. But what I want you to look at are the scores. So if you see his AZ Bio Quiet, those are those sentences, 68% in one ear and 81% in the other. That's pretty good, right? So he's able to have a conversation. He's doing pretty well, it seems, in a quiet scenario. If you go down to his +5, so that's a little bit harder noise situation, he drops to 31% and 45%. So he's scoring almost half of what he scores in quiet. Realistically, we're never in complete silence. So those quiet scores probably aren't very accurate. What I think is so interesting about CNC word scores, just the single word, is look at the difference of the word score versus that sentence score. And CNC word scores are in quiet. No noise in the background, but you're only able to give them points for the sounds they get correct. So it's a much more distinct test. Interestingly enough, it looks pretty similar to his AZ Bio +5 scores, right? So because I like the CNC word scores and because I knew this guy pretty well, we said, you know what, let's go ahead and try and implant one ear, hoping, of course, that we were going to preserve hearing. Fortunately, did a pretty good job with that post-op audio. The hearing looks great on the left side. And so pre-op again, there's where he was in the green. And then 3 months post-op, you can see he is just excelling with the cochlear implant. He does have an acoustic component, so he's using acoustic and electric signal. And then about a year after he's had his device, he reported vertigo. He said that sounds were duller. We repeated the unaided audio, and he had lost all of his residual hearing in his CI ear. So again, here is his pre-op and then his 3 months post-op. So at 1 year, we tested him again. He was not using the acoustic component, so only the CI. And he's not doing quite as well as when he had the acoustic component, right? But he's still significantly improved from where he was with just his hearing aid. He's super happy with his implant. He really wished that he still had that residual hearing. I think this is a great example of why you guys need to be so diligent about preserving that residual hearing. And it's a great example for us to use too, to patients of, hey, you know, why don't you try the acoustic component, because it really does show an improvement over what you could get with the implant. My second case is a 91-year-old. I love the 90-year-olds. I really love working with pediatrics and especially teenagers. And sometimes I feel like those 90-year-olds can be, they act a little bit like teenagers sometimes. So this lady had 20 years of hearing loss. And if you notice her right ear, she had not used a hearing aid in 15 years. No real surprise there, considering she didn't have any hearing in the right side. Lived alone, felt isolated, avoided social settings. She had a big family and they did come by pretty routinely during the week, but she couldn't understand them on the phone. And so they had to make the effort to come see her. The family, of course, was pushing for her to get a cochlear implant. Interestingly, her primary care told her she was too old for a cochlear implant. Just a disclaimer, there is no upper age limit for a CI. I think when I was at MUSC, the oldest guy we did was maybe 97. Here we evaluated a 99-year-old the other day. So if you look at the aided scores again, here's the left ear. So she does have some understanding on the left side, but really nothing on the right. Now, I wish I'd made some polls for you guys to tell me if you would have implanted the right or left ear. I'm a big fan of implanting the better ear if the patient will go for it, which is sometimes not what the surgeon recommends. So for her, we did recommend that she go for the better ear, and she did a little bit better. Now, if you look at the CNC word scores, that's not enough to be a significant change. However, if you look at her sentences in quiet, that is a significant change. Because she's in an isolated area, mostly at home by herself, doesn't really watch TV with volume, you know, she could tell that she was doing better. She loved her implant, super happy with it. On paper, this may not be necessarily a success story. However, when you talk to her, it's a huge success story. On the day of the activation, she was able to understand her daughter without lip reading, and much more easily than with the hearing aid. This was before Dr. McCracken had his quality of life questionnaire. I'd be curious to see how she would have scored preoperatively and postoperatively, but I feel sure that it would have been a significant improvement. So with our adult candidacy, remember, this is what we have right now with the adults, but the kids look very different. Oh, Dr. Meyer says could have been a bilateral. Definitely could have been, but she did not want to have the second ear implanted. So with pediatric candidacy, here's where things don't look quite as great. We've made all these gains with the adults, but the children really still are down here in the profound range if they are a year to two, well, actually less than 2 years. Over 2 years is still severe to profound. So anything outside of this red box is considered off-label. And they have to have less than 30% words correct. So if they can score 40%, they still have good enough hearing to not be considered a candidate. It blows my mind, but the FDA doesn't really make sense sometimes. EAS and hybrid criteria, not approved for kids. SSD, asymmetrical hearing loss, only for 5 years and older, which again doesn't really make sense considering what we know about congenital deafness and length of time without auditory input. You know, I tend to think that this age is going to reduce at some point. We're certainly implanting, I mean, I think we've been implanted as young as 3 here. We do want to hope that there's not any interference from the cochlear implant with the normal hearing ear. But I think we're a little bit a ways from being able to tell that with the kids. So in summary, CI evaluations are complex. The candidacy is much, much more than the audiogram. I think AIDA testing is essential to assess hearing aid benefit, especially for pediatrics. If you are working with audiologists who do not want to assess functional benefit of hearing aids with kids, you should probably find new audiologists. A skilled CI team is necessary to appropriately manage the whole patient. And, kids and adults can benefit from off-label and non-traditional candidacy. The implant can still be beneficial for them. And really what we see mostly is improvements in hearing and mostly quality of life. And I think you can't discount the importance of improved quality of life post-CI surgery. I have to thank my team. This is a super comprehensive team. All of these audiologists do work with cochlear implants. We have 2 full-time psychologists. We also have multiple speech language pathologists, an educational specialist who works with our IEPs. We have a social worker who helps us with insurance for most of our kids, and then all of this clinical support. So we have 2 full-time clinical coordinators, and then we have a couple of clinical assistants who help us with testing and making sure that children will stay in their high chair and things like that. Lastly, CI 2022 is coming up in Washington, D.C. in May. Abstracts close on Friday, so please submit something. We want it to be a great conference. Registration will open in December for the actual conference. All my references are here. And I appreciate your time and your effort, and I really appreciate being able to present at MUSC. It'll always be near and dear to my heart.
Thank you so much, Dr. Holcomb. That was awesome.
We love you too.
So comprehensive.
What did he say? What did he say?
He said we love you too.
Oh, he's so sweet. If anybody has any questions, I'm happy to take them. I know I went over. Otherwise, Mallory, you're welcome to send out any of the slides if people want them. If they do that, maybe we'll send you one that doesn't have pictures on it, just so I don't send my pictures everywhere.
Anybody have questions? I have one. If you have just a minute. I'm interested in cognitive impairment and pre-op evaluation and how we use that. And we're starting to try to look at that, but it's tough because of the limited testing tools that we have. So I'm just curious what you guys do at University of Miami, how you involve the psychologists. What do you think about when you get a mild cognitive impairment, moderate cognitive impairment? Do you alter your testing, and how do you counsel?
Yeah, it's a good question. Because we just do a MoCA screener, the reality is they could score normally on the MoCA screener and still have mild cognitive impairment. So the only thing we really adjust if they're scoring kind of below that cutoff for the MoCA screener, we'll adjust how heavily we counsel the families and their support system of, that it may take a little bit longer for them to adapt to the implant, that, they may not want to concentrate so much on scores of speech recognition in the sound booth, but maybe more, how the quality of life is going to be affected with the implant. So it just changes the conversation a little bit, but it doesn't necessarily keep us from implanting them by any means.
Awesome. Cool.
Do you guys use the regular MoCA or the MoCA HI?
No, we just use the regular MoCA. There's also a Spanish version, so that helps us since, 50% of our CI patients are Spanish. So, and Dr. McCracken, hopefully you've had some people from Miami fill out your survey. We've been sending it out.
Zero people from Miami have filled it out. Ohio State, yes. Michigan, yes.